Good afternoon, everyone. We will go ahead and get started. It is my honor today to get to introduce Andrew Beck. Andy is a professor of pediatrics at the University of Cincinnati. He has led groundbreaking research that has uncovered how neighborhood conditions like toxic housing and socioeconomic deprivation predict adverse health outcomes for children and explain much of the racial disparities that we observe. He has used this as a basis for developing and sustaining cross-sector partnerships with community-based organizations and other key stakeholders that has resulted in improved child health outcomes for the most vulnerable children in Cincinnati. He also has leadership roles within the Child Health Equity Center at Cincinnati Children's and within the Ohio Medicaid ACO. He also has ties to our UCSF community, serving on the advisory board for the UCSF-based Siren, a research network aimed at social and medical care integration. Finally, I consider Andy to be a mentor and friend. His work has had a huge impact on the way I view my work, and I'm so grateful to him for all the guidance that he's provided over the years. I'm really thrilled that he's speaking here today because I think we have a lot to learn from him. Before I turn it over to Andy, I want to just remind everyone to use the Q&A feature of Zoom to put your questions in, and we'll have a question and answer portion right after his talk. With that, I now welcome Andy to begin his talk. Thank you, Andy.
Thank you so much for that introduction and for having me here today. I am really excited to be able to speak to this group and to be able to speak on a topic that I find so important, which has really been the thrust of my work over many years, including much work that I've done with Sharad on the intersections of neighborhood health and opportunity. Here are my objectives for our time together today. First, I'd like to define some key terms, really think about neighborhood and their link to our sense of community. I hope to illustrate the importance of neighborhood to a range of outcomes relevant to children and adolescents. And importantly, I'd like to think about opportunities we all might be able to take advantage of for neighborhood-based action, engagement, and improvement. But let's start by conceptualizing neighborhood and community. And I might try something, bear with me. If you'd be so willing to try a little interactive approach. If you use the QR code or the slido.com site, I'd like to ask and am curious what you think of when you hear the term neighborhood. What word comes to mind? What concept comes to mind? And let's see if we can't get some responses. I see some typing, so that's a good sign. Community. Resources, neighbors, people, families, friends. Mr. Rogers, and perhaps you noted the font that I tried to use, at least in the beginning slide. Groups of homes and shared spaces, house. I see friends and people getting a little bit larger, zip code. These are all really important and good terms that I think are highly relevant. Public commodity. Okay, thank you. This is good. Here's some definitions that I found on neighborhoods and communities. And in a moment, we'll think a little bit about what neighborhoods and communities mean to each of us. But I think these definitions are instructive. The top one, neighborhood, comes from Healthy People 2030, which define neighborhoods as the places where people are born, live, learn, work, play, worship, and age. And I encourage you to remember that cadence of word, the places where people are born, live, learn, work, worship, and age. That will come back into our lexicon here in a few moments. Community is a related term here defined by CDC as a specific group of people often living in a defined geographic area who share a common culture, values, and norms, and who are arranged in a social structure according to relationships the community has developed over a period of time. In many respects, a shared story, a shared history. So as we think about what neighborhood or community means to each of us, I'd ask you rhetorically, what neighborhoods or communities do you have meaningful or emotional connections to, and why? I would imagine many of the words that people typed into that Slido exercise probably find their way into an answer to that question. As I think about this question for myself, 3 neighborhoods come to mind. Brighton, New York is my hometown. That's where I grew up. Montgomery, Ohio is where I currently live. And the neighborhood that I'd like to spend a bit more time talking about is a neighborhood where my mother grew up and where I lived during medical school, that being Squirrel Hill in Pittsburgh. I have a deep connection to Squirrel Hill. Pittsburgh was often a second hometown to me, and Squirrel Hill was where I went to visit family many times a year. Here are some pictures of my mom's family as she was growing up. You see in the top left, pictures of her mother and her grandmother. You see her father down below. You see her and her sister in the middle top, and her family around a cultural garden that my maternal grandfather and his family provided support for. And then you see the picture at the bottom, an opportunity to embarrass myself, and I suppose my sister too. But this is a picture of us at that same house where my mom grew up, in that same neighborhood, a connection that runs across generations and that stretches into our sense of family and history. Squirrel Hill is also an interesting place. There was a book written that I imagine not too many of you have read, but it was on my grandfather's shelf, entitled The Jewish Experience in Western Pennsylvania. And this was a history looking at almost 200 years worth of history in that part of the country, with a good bit of text devoted to the Squirrel Hill neighborhood. In fact, on pages 190 to 191, they note that the Squirrel Hill that came to be what we know it today was really developed in the early 1900s as the Jewish colony of Pittsburgh, where Jewish residents made a living in the neighborhood from grocery or drugstores, restaurants, butcher or barber shops, clothing stores, those places where people are born, live, learn, work, play, worship, and age. That defined geographic area, one with a common culture, with values, with norms, with a shared story. Now, of course, many of you are perhaps more familiar with this book or with the events that led to the publication of this book, the Tree of Life synagogue shooting, and really the soul of Squirrel Hill being laid bare before the world to see. On this book, on page 19, Mark Oppenheimer writes that everyone used the same supermarket. Everyone walked the same sidewalks. And for the most part, they nodded warmly as they passed. This shared story, this shared view, this commonality of where people were born, live, learn, work, play, worship, and age, all going into a sense of what made Squirrel Hill not just a neighborhood, but a community. Now, Squirrel Hill is but one neighborhood in one city, but I would suggest that neighborhoods and the communities that they either support or impede are not always idyllic. They're not always welcoming or inclusive, and they're not always on the receiving end of investment and opportunity. But rather, it's the balance of neighborhood assets and risks that influence, in many respects, the health and opportunity of those that call it home. So a few years ago, we posed the question to many of our patients and their families about how do they view their neighborhood, their sense of community, and the ways in which those communities either promote or impede health and well-being. We asked a number of families coming for care in our primary care center to simply draw a picture of their neighborhood as they saw it. And here are some examples. Some that look fairly positive. This is an example of a drawing by a family. You see them depicted on the bottom. You see houses, you see trees, you see Mitchell, which is a road that runs through this particular neighborhood. Looks like a reasonable place to live. Another one that looks rather positive. Series of homes, you see grass, you see neighbors, and this particular artist noted that thanks for the lookout, no problem. There's a job fair. Welcome to the neighborhood, all warm well wishes that perhaps illustrate a neighborhood that made health more accessible. But not all of them were positive. A few examples of the ones that displayed more challenge. First, this one. This one included a busy street with 4 houses, and that structure that is on that particular street was captioned on the back of this particular drawing as houses on my street with a crane knocking them down. Now, importantly, this picture was drawn by someone who lived very close to Cincinnati Children's Hospital. We were in the midst of building a new critical care tower, and that required that a road through our adjoining neighborhood needed to have many homes flattened. So in many respects, the negativity of this particular experience of neighborhood was promulgated by Cincinnati Children's. And there were other examples that illustrated the challenges that many of our patients and families face every day. Here is a picture of a neighborhood. You see cars in the street. You see a person in the top central part of it firing a gun. And there was a caption on the back of this drawing that said that this was a shooting during the day. They're used to the sound of gunshots. And those cars are actually people speeding by in a drag race. It also says Wild West depicted at the bottom corner. And one last example here of these drawings from our families displays a neighborhood with children's buildings in close proximity. And then someone residing within a particular home noting that I wish the killing would stop. I'm afraid to go out and play. Another down in the bottom right, move out of the way. There's a shootout. Drugs are being sold. All in the backyard of Cincinnati Children's Hospital, illustrating the risks and challenges some might face in the places that they call home. These drawings were matched by some insightful comments from hospitalized parents during a qualitative study we pursued a few years ago. We posed questions about challenges relating to the transition from hospital to home. And we asked individuals, or we evaluated responses based on the poverty rates in the neighborhoods in which they lived. So one theme that everybody said was that it was really hard. Hospitalizations are very difficult events to navigate, but the difficulties seemed in many respects different if you lived in a neighborhood with higher rates of poverty than in a neighborhood with lower rates of poverty. One noted that it's impossible to be at the hospital 24 hours a day. I don't care who you are. I don't care if you're a single parent. The other, in a more affluent neighborhood, focused more on all those tasks that needed to be completed at the end of a long hospital stay. Laundry, groceries, all eventually get there, but the kids got to get back to their day-to-day. Others noted about leeway. Those in more impoverished neighborhoods had a great deal of challenge trying to navigate post-discharge needs. It takes 4 hours to get to the pharmacy, 2 hours to get there walking, 2 hours to get back. I can't do it. Whereas another had a primary care office that was able to bend over backwards to get them in. With the sick kid or a follow-up, they'll get you in the same day. And then a final example highlighting that some were pretty plumbed out by a hospitalization. For those who lived in more impoverished communities, they were left in the hospital with no money, no food, no gas, basically eating nothing but cereal that her daughter, the patient, doesn't eat that I could sneak in before the doctors come and see. Quite different from the parent whose work worked with me a lot, allowed me to work from the hospital. So very different experiences emergent from varying neighborhoods that our patients and families call home. So how might we learn from neighborhood or learn from place in ways that can drive us to create more insightful conclusions in our research and to drive improvement both at the bedside and at the park bench, so to speak? One thing that we've commonly used neighborhood or place for is to more effectively understand spatial variation in both assets and risks. Analytically, it's allowed us to assess associations between place-based factors and outcomes, in many respects enabling pattern recognition either at the patient level or population level. We've also explored the use of predictive analytics, understanding the balance of asset and risk to understand the likelihood in which a certain individual or population of individuals experiences a certain outcome or event. And the use of neighborhood or place in certain studies also allow us to think about how we might adjust for unmeasured or insufficiently measured variables or differences. A few final key terms before we bridge neighborhood and health more specifically emerge here. One, we think a lot about GIS, or Geographic Information Systems, those capabilities that allow us to capture, store, analyze, manage, and present data in a meaningful way that are linked to location. The act of geocoding, assignment of a code, usually numeric, to a geographic location. Most often, we think about this in terms of our zip code, but one can also think about census tracts, neighborhoods, or other boundaries geospatially that allow us to understand the distribution of a certain outcome. Shapefiles are those files that allow us to describe geometries either as points, as lines, or as polygons, certain shapes. And geomarkers is what we use as a term to describe objective, contextual, geographic measures that influence or predict the incidence of outcome or disease. So with these terms in mind and these potential uses of place-based analytics in mind, let's move toward the bridge between neighborhood and health, the bridge between place and health. And frankly, the understanding of this intersection goes back to the dawn of medicine. Hippocrates wrote in the 5th century BCE about airs, waters, and places, about the relevance of water, of ground, of the mode in which inhabitants live, of what their pursuits were in those particular areas, and their relevance to health outcomes. Of course, this was accelerated more recently in the 1800s when Edwin Chadwick started to make maps of health outcomes, linking life expectancy to poverty, looking at associations between deaths from cholera and respiratory disease and location across leads. The map you see on the right comes from Edwin Chadwick in the 1840s, using an early GIS system, layering data, layering different markers of both health outcome and social context to drive inference. And of course, this was followed not long after by John Snow's famed cholera map, which really forms the basis for much of the GIS work that we see today. There's also this age-old debate that has occurred in public health and population health as it pertains to neighborhoods and health about composition, context, or both. Indeed, is it the difference people make to places, that is, who composes certain communities? Is it the difference place makes to people, that being context? Or in the words of Berkman and Kouachi in their book Neighborhoods and Health, I would suggest that this is a false dichotomy, that by and large, people create places and places create people. And those people and places create outcomes and outcome distributions, which is really what I think we become most interested in today. So thinking about population health as being driven by that concept of distributions, I'll define this term from Kindig and Stoddard, published in this AJPH article in 2003, that population health is the health outcomes of a group of individuals, including the distribution of such outcomes within that group. So it's not enough to say that the average outcome, the average life expectancy, the average hospitalization rate is this. We also need to look at the distribution of that variable to understand what the differences are and what the range is across a particular population. Population health research, thus, is the study of the conditions that shape distributions of health within and across populations, and of the mechanisms through which these conditions manifest as the health of individuals. Indeed, the conditions, the distributions, and the mechanisms. And in many respects, the conditions can be defined as the social determinants of health. And indeed, these are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And you'll recall that the definition I provided early on of neighborhoods as the places where people are born, live, learn, work, play, worship, and age looks very similar, that being the places where those conditions are experienced. So that's conditions. Distributions, of course, comes next. And so in my mind, you can't define or think about population health without simultaneously thinking about health equity. The Robert Wood Johnson Foundation defines health equity as the state in which everyone has a fair and just opportunity to be as healthy as possible. And this requires removal of obstacles to health, such as poverty, discrimination, their consequences, powerlessness, and lack of access to a range of conditions that in many respects determine health outcomes. And from conditions to distributions, we go to mechanisms, thinking about the ways in which conditions ultimately affect those distributions. This schematic from the site cited at the bottom of this page, I think is a useful frame that when we think of structural determinants of health equity, in many respects, we think of those macro level societal factors that determine the determinants, determining social factors such as presence of food deserts. So if structural determinants include historical factors like redlining, the social determinants include factors like whether you live in a food desert, and in turn, social risk factors and social needs experienced by certain individuals within that particular community emerge as hunger and food insecurity. So redlining to food desert presence to food insecurity. So turning to some data to highlight once again the conditions, distributions, and mechanisms. I displayed this map, which I put together from data that I imagine many of you have seen before, looking at a census tract map of San Francisco with the green to red distribution of those census tracts colored according to life expectancy. And just highlighting a couple areas on this particular map, one to the west central side of the city where life expectancy is approximately 85 years. Another one to the northeast part of the city where life expectancy is about 75 years. So a 10-year life expectancy gap across a relatively small geographic area. Now, if you go beyond San Francisco proper and go into parts of Oakland or other parts of the Bay Area, this distribution would seem even larger, with some areas still in excess of 85 to 90 years of life expectancy, other years hovering just above 60 years. Huge variability as you navigate relatively short geographic areas. Now, life expectancy is a pretty crude measure, but what does this look like in terms of distribution for other outcomes of relevance to children and families? This was an analysis a few of us did a few years ago, looking at hospitalizations for ambulatory sensitive conditions in Cincinnati and Kansas City. This work was led by Molly Krager at Children's Mercy in Kansas City. And we found that for these particular diagnoses, asthma, bronchiolitis, pneumonia, and on down, the hospitalization rate varied considerably across levels demarcated according to the Child Opportunity Index. So the Child Opportunity Index is a geospatial index that can be applied to census tract geographies. And they're ordered in diminishing order of child opportunity. So very high opportunity tracts have indicators expressing positivity related to educational opportunity, health and environmental opportunity, and socioeconomic opportunity. And then they go on down to very low opportunity tracks, which have more limited access to quality early childhood education, green space, food, and socioeconomic resources. And what I urge you to look at in this particular table is that for each of these conditions, all of which are purportedly ambulatory care sensitive, there is a stepwise gradient as you go from very low to very high opportunity levels with respect to hospitalization rates. So just look at that top line for asthma. The hospitalization rate was 29.3 per population in the very low opportunity tracks, all the way down to 5.3 in the very high opportunity tracks. When we did a slightly deeper dive in Cincinnati, looking at some similar diagnoses across our service lines in the hospital, we found very similar gradations, this time by poverty quintiles. And we started to layer these atop on a map not too dissimilar from that developed by Chadwick or Snow, to try and begin to say, what was it about certain communities that were so-called hotspots for hospitalizations, and then what was the array of risks and assets within those particular communities that might enable us to move toward action, toward improvement. This particular map that you see here highlights the Avondale neighborhood, which encircles our hospital, depicted centrally as the H. And then for some of those assets which we may leverage, you can see schools, primary care and school-based health centers, and pharmacies, all potentially indicative of partners. Another data slide. This is looking at neighborhood all-cause inpatient bed day rates across Hamilton County, Ohio. That's Metro Cincinnati. The numerator for this work was the number of days kids from particular neighborhoods spent in the hospital. And the denominator was all children living within those particular neighborhoods. And the y-axis are the 80 or 90 neighborhoods that compose Hamilton County, Ohio. Now, most of you probably don't have great knowledge of Cincinnati neighborhoods, and the print is also likely small, so I don't expect anyone to read through these neighborhoods, but rather I expect you to see the sheer variability as you go from neighborhoods on the top of this figure to the bottom of this figure. Very high inpatient bed day rates, all the way down to very low inpatient bed day rates in neighborhoods where we have a near population sample. So just about every day a child spends in the hospital in our community is reflected in these data. So then how do gray neighborhoods differ from green neighborhoods? What might we learn as we look to census variables, just as an example, to understand the differing conditions in which children are growing, living, and aging? So here's just a select group of census variables with box and whisker plots illustrating the distribution of that variable within the quartiles of neighborhoods. And again, more important than anything else is the pattern. See the stepwise gradation across every single one of these variables, whether it be on racial composition, illustrating the degree to which Cincinnati remains a very racially and economically segregated city. You can see additional variables included on this related to educational attainment, vehicle access, childhood poverty, unemployment rates, measures of vacant housing, illustrating housing quality, all illustrating the different conditions that are driving these distributions. Now let's take a deeper look at this variable. I mentioned a moment ago that Cincinnati, like many cities in the United States, is quite segregated racially. And those same neighborhoods that tend to be disproportionately populated by those who identify as Black or African American tend to be those with limited opportunity for advancement. This, in many respects, is an illustrated fact of codified structural racism that has emerged over many years. Now, I imagine many on this call have seen this map. If you haven't, I retrieved it from this amazing website that the University of Richmond administers on that provides a library of redlining maps for all across the country. This is a redlining map from the city of San Francisco in the 30s. From this University of Richmond site, you can interact with this map and see some of the overtly racist or xenophobic language that is connected to those neighborhoods outlined in red and yellow. So here, just as an example, this particular neighborhood, again, to the north and eastern part of San Francisco, is composed with few exceptions of the working class, so illustrating in this particular case a degree of classism. And then there's quite a concentration of, quote, Red Russians and other foreign elements in the area, illustrating an anti-immigrant sentiment which colors many of these redlining maps. Now, this stands in contrast to the western part of the city, where inhabitants are, quote, largely white collar, businessmen, junior executive type, where there are no racial problems and the likelihood of there ever being is remote. Now, I urge you to recall that life expectancy map I showed a moment ago. If my lines are correct, the same neighborhoods that are depicted in red in this 30s era map tend to be those neighborhoods depicted in red in this life expectancy map that emerges from more modern times. Similarly, those neighborhoods demarcated in green and blue on the redlining map tend to be those same neighborhoods on the life expectancy map. A balance of risks and assets that truly represents the legacy of racist and discriminatory structures and systems. Now, in Cincinnati, we've tried to think about these links and identify ways in which we may come to understand them and use that history to define improvement objectives to improve outcomes and narrow gaps. So this is a chart that we developed over the last couple of years, looking at racial inequities in childhood hospitalizations for kids here at our own backyard. The way we structured this particular chart was looked at the top 30 reasons why children were hospitalized at Cincinnati Children's. We then calculated hospitalization rates using population denominators for youth in Cincinnati who identify as Black or African American, and those that identify as other racial groups. And then we looked at the number of excess admissions experienced each year by our Black youth in Cincinnati. And if you just look at that top line, asthma, as one of our top reasons for admission, the number 294 represents nearly 300 excess admissions every year experienced by Black youth compared to their non-Black peers, a side effect of multi-generational racism that is emblematic of continued disinvestment in certain neighborhoods and communities that have suboptimal opportunity for health and well-being. We next sought to estimate neighborhood-specific racial disparities or inequities and determine how much was mediated by these neighborhood-based exposures. And one of the tools that we've often used is a directed acyclic graph to begin to understand defined assumed causes of an outcome and the link between exposure and outcome. Just a short primer on directed acyclic graphs, or DAGs. You see the exposure directed towards the outcome. A mediator is along the causal pathway between exposure and outcome. A confounder affects or is associated with both exposure and outcome without being on that causal pathway. And as we developed our DAG for this particular question, we tried to think about what measures we might adjust for to understand how much of the racial inequity that we were seeing was truly mediated by place-based factors. So to pursue this study, we looked at multiple years worth of data for children living within Hamilton County, Ohio. There's about 190,000 children and adolescents less than 18 years of age that live in this particular county. We used a geocoder and geomarker assessment tool called dGauss to geocode each hospitalization event to the census tract level and merge with data available both here in Cincinnati using public sources as well as national sources like the US Census. Our outcome was census tract hospitalization rates. And to enable evaluation of the effects of structural racism, our exposure variable was a population-based measure of marginalized racial or ethnic group membership, conceptualizing as emerging from those complex historical processes like redlining. So here is our DAG. You can see the ways in which we hypothesized that the complex historical processes would influence our primary exposure, which in turn would either be mediated by or confounded by a range of other factors. We sought to adjust a model for these place-based factors in an attempt to understand and isolate the remnant effect. And here were our results looking at all cause and condition-specific models. On the figure, the red circle is an unadjusted racial disparity rate ratio, or in essence, the amount of excess hospitalizations that could be that would be linked to a 10% increase in the census tract percentage identified as a member of a minoritized group. The blue line is the adjustment that essentially explains adjustment variables and pathways. And what we found was that across all causes for hospitalization, nearly all of the racial disparity or inequity that we saw was explained by neighborhood-based variables like poverty, socioeconomic deprivation, housing stock, and other variables that detailed information about the conditions in which a child was born, grew, worked, lived, and aged. You can see some variability in the amount of disparity explained for other conditions, but you see that by and large, what we're seeing is further evidence of the effects of multi-generational disinvestment and different experiences of how neighborhood-based risks and assets are balanced. Okay, so in the last few minutes, I wanted to really move in the direction of pursuing neighborhood-based action, engagement, and improvement. And someone mentioned Mr. Rogers at the start. I'll bring him back up once again. And for those that may not know this, Mr. Rogers lived and worked in Squirrel Hill. He was a Pittsburgh native and was a member of that particular community. And I'd like to think that that experience prompted him to note that in every neighborhood all across our country, there are good people insisting on a good start for the young and doing something about it. And so I'd like to ask that you do one more of these Slido activities and type in this time the name of a neighborhood or community partner with whom you would love to work with or are already working with in pursuit of better, more equitable outcomes. So let's give that a minute or two and see the types of organizations people add. There's some good ones that I will be looking up after we're all done. Oh, Soccer Without Borders. That's cool. All right. Well, thank you. I'd encourage you all to be thinking about this question because I think it's really central to so much of the work that we might do and might do with partners who are similarly devoted to improving conditions for community members. Maybe one more minute. I'm enjoying this. All right, thank you. So as you either are working with those groups or consider ways in which you may work with them, I'll highlight a few of the examples of things we're working on in Cincinnati with this idea of clinical community partnership for the pursuit of population health and health equity in mind. And it of course starts with asking the right question. There's been a number of researchers, clinicians, improvers who've really thought about what is the role of social needs screening and response during clinical encounters. National Academy of Medicine recommends standardized collection of certain variables, including residential address, to help us understand the distribution of certain outcomes. They also stress the importance of assessing health-related social needs and social risks, the integration of much of that data into the electronic health record. The American Academy of Pediatrics agrees, encouraging screening to facilitate prevention services and to improve the health of all children. The bold, something I added, illustrating the degree to which this is linked to our pursuit of population health and health equity. Within the context of screening, but also within the context of place-based measures, we've sought to really understand the cross-sector health system, from city to neighborhood to household to child, understanding ways in which certain geomarkers or geospatial variables might be linked to meaningful interventions. Here's a map of the Avondale community once again. The background here is looking at asthma-related hospitalization rates. And then some of the variables we've added to the mix here look at housing code violations. What are some measures of housing stock that may be amenable to robust community-based interventions like housing inspection, legal advocacy, or development of affordable housing structures, and ways in which we've leveraged a partnership with our our legal aid counterparts has led to something akin to what you see here, an Epic-based electronic health referral order that looks much the same as a referral to gastroenterology would look, except in this particular case, we're referring to housing-related experts who are best suited to advocate for healthy housing conditions within this particular neighborhood. Our most robust clinical community partnership is this medical legal partnership. Ours is called the Cincinnati Child Health Law Partnership, or Child Help. And this is a program whereby we refer patients and families with unmet legal needs for legal advocacy. And these referrals primarily emerge from our primary care centers, but we have started to bridge referrals to subspecialty colleagues. Recently, we pursued a study looking at a recent set of multiple years worth of data of Child Help's actions. We used some advanced statistical techniques to emulate 100 randomized trials, matching kids referred to legal aid with those who were not on age, referral date, or concurrent visit, the history of prior hospitalizations, and we adjusted for some remaining differences, and found the children who had been referred to legal aid had a hospitalization rate the year after referral that was 38% lower than had they not been referred. And the chart on the right illustrates this relationship. Orange represents a before period and an after period for intervention patients. The turquoise or green represents for control patients. So a meaningful difference made by legal advocacy. It's also enabled us to develop an approach to pattern recognition and action. Here's a map of Cincinnati. The background grid are looking at specific blocks within the city and housing code violations using data provided to us from the Departments of Building and Inspections and the Health Department at the City of Cincinnati. And this type of effort was used when overlaid with health outcome data to support the pursuit of litigation against an out-of-town landlord who wasn't holding up their end of the bargain, relevant to the experiences, the conditions in which 976 tenants were living in this Williamsburg apartment unit. And there's currently ongoing litigation pursued by the city solicitor's office to try and move toward better housing conditions for residents. We've similarly sought to bring quality improvement to a neighborhood-based approach. We pursued efforts in the Avondale and Price Hill neighborhood, another neighborhood within Greater Cincinnati, to reduce inpatient bed days and eliminate hospitalizations for children within these particular communities. We saw the relevance of starting small, developing improvement strategies with community partners, and really understanding what it would take at a small scale to then move towards a larger scale. And over a few years of improvement efforts with partners, we saw the fruits of our labor with proactive outreach, equitable resource deployment, an accountable system, cutting inpatient bed days by about 150 days per year, about 80 admissions per year, and a gap with the rest of the county cut by nearly 50%. But clearly there's a need to sustain scale and spread. And one of the ways we've sought to do so is by leveraging two things that Sharad alluded to at the start of this hour. Our Medicaid ACO contract, which is called HealthVine and covers about 120,000 kids on Medicaid in our part of the state. And the Child Health Equity Center at Cincinnati Children's, which is focusing most of its early efforts on the 10 most structurally disadvantaged neighborhoods in our county. A shared initiative of HealthVine and the Fisher Center is something we call the Health Equity Network. The Health Equity Network is built upon shared purpose that we seek to collectively reduce inequities in child health outcomes by using systems thinking and connections between system members and partners. Those included within the Health Equity Network are subspecialty teams from across the hospital who are connected with community partners, each devoted to reducing a gap in their own clinical setting while contributing to a larger move towards improvement across the Cincinnati population. It's been important for us to think diligently about understanding both numerator and denominator for this work and pursuing rational segmentation by race, by payer, by neighborhood, so as to ensure that we were actively mitigating inequities. The theory behind the Health Equity Network is though certain conditions or certain clinical areas across the hospital surely differ, the drivers of inequities are likely to be the same, thus providing an opportunity to pursue formal testing and learning collaboratively makes sense. And one of the things I mean by this is depicted by these particular maps. Each maps of Cincinnati, the background blue to red, displays varying rates of census tract poverty. And the dots represent admissions for different conditions: sickle cell, diabetes, mental illness, asthma. And those certain conditions are differently common. Asthma and mental illness, of course, more common than sickle cell and diabetes. The general clusters of these dots tend to follow similar patterns. They tend to be more clustered in those more impoverished communities, which really pushes us to get to those common root causes and common strategies that could be enacted across conditions. And so this theory is perhaps best illustrated by the key driver diagram, which the Health Equity Network uses to guide our work. These are those factors which we've collectively with our clinical partners and community partners determined to be those things which we think most important to lead to better, more equitable outcomes. The importance of trusted relationships, met needs, built connections across the health and community systems, right care at the right time, right place, and in the right way, and a learning infrastructure that allows teams, whether they be inside the hospital or outside the hospital, to truly learn from one another. The 10 current teams are depicted at the right. You can see they're focused on different things, often different conditions, but again, the drivers of the inequities that they're working on likely to be the same. The cadence of work for the Health Equity Network involves two touch points each month, where individual improvement teams come together in action period calls to share what they are working on, what's going well, what's going poorly, what they envision as a future step to drive towards improvement. These are then added to by what we call solutions labs, which really take a deep dive into one of the shared drivers to think about what it might take to move towards improvement. So, for instance, the medical legal partnership and its spread to subspecialty clinics has been the topic of a longitudinal solutions lab. We've also sought to align with other efforts happening across Cincinnati. One of the citywide efforts that is occurring is something called the Community Table, and that's tied also to our All Children Thrive Learning Network, which really is trying to understand what would it take for all children within Cincinnati to truly thrive. What are the ways in which we Cincinnati Children's can support the pursuit of equitable health? But how might we also work with key leaders and residents of Cincinnati to focus on economic mobility, emotional well-being, and educational success? And so we've convened partners from across the city, developing shared vision and theory about truly understanding what would it take for children to thrive, to narrow gaps in health outcomes, in preventive outcomes, but also outcomes like kindergarten readiness and graduation. This is a picture that I just love from earlier this summer, where a group of individuals from across so many of those domains came together to begin to define what it meant for children to thrive and what it would take to get there. And you can't read it because we're standing in front of it, but that whiteboard behind all of us represents the work of a couple of days trying to think about relationships between key factors, many rooted in place in community, that would need to be leveraged to either promote those factors that could lead to thriving or stand in the way of those factors that would impede thriving. So as I close, I want to come back to this focus on consistent, meaningful collaboration with neighborhoods and with communities for population health equity and for hope that we might achieve population health equity. And there were a few quotes that I want to just share that relate to this pursuit. One is by activist Majora Carter. These first two quotes actually come from the National Museum of African American History at the Smithsonian. And she noted that no one should have to move out of their neighborhood to live in a better one. And to me, this highlights the reality that neighborhoods can lead to premature death. We have data that show that. But so too can they promote long, healthy, meaningful, and productive lives if we ensure that they have the supports and assets which they should. This quote comes from Ralph Ellison, notes that it's not geography alone which determines quality of life and culture. Those depend upon the courage and personal culture of the individuals who make their home in any given locality. It's this reality that neighborhood-based assets and connections can tip the balance toward life, health, and opportunity. And I'd like to close with this picture and with a quote from not the man on the right, who we know to have provided us with so much wisdom about the relevance of racial equity in association with health, but the man on the left. This particular individual was a child of Squirrel Hill. He was a good friend to my grandfather. He married my grandparents. He went on to rabbinical school and was a rabbi at a synagogue in Atlanta, where he befriended Martin Luther King. On account of that friendship, his synagogue was bombed. And he stood firm. And from the pulpit in the days following that bombing, he noted that this despicable act has made brighter the flame of courage and renewed in splendor the fires of determination and dedication. It has reached the hearts of men everywhere and roused the consciousness of all people united in righteousness. All of us together shall rear from the rubble of devastation a city and a land in which all men are truly brothers, and none shall make them afraid. And to me, there are few quotes that highlight the degree to which out of inequity, inaction, and discourse can come justice, progress, and community. And I would suggest health and opportunity will soon follow. Now, I want to acknowledge a ton of individuals and entities here in Cincinnati and all across the country who have contributed to this work. I'll also especially acknowledge my friends and partners at Siren for being such a strong resource for this work here in Cincinnati and all across the country. And with that, I'll thank you and hopefully have a little bit of time for discussion, and certainly am also reachable with questions and comments should we not have time today. Thank you.
Thank you so much, Andy. That was a wonderful talk. I'd like to invite any questions. I have a question here in the audience. Thank you, Dr. Beck, for a wonderful grand rounds. Just wanted to share a resource for researchers or community members interested in exploring place-based social determinants of health in California, calling attention to the UCSF Health Atlas, which you can find online. I have a couple questions while we wait for, oh, here's another question. I'll let them. Okay, so this attendee asked, what aspect of population health do you think was most affected by the pandemic experience and will have the biggest impact in the long-term health and happiness of the children who lived during the pandemic?
Yeah, what a great question. I think so much has been affected by the pandemic. I think the one that I probably experienced the most as a clinician, excuse me, was probably mental health. I certainly think that it's affected our patients and their families. I think we hear it routinely in our clinical settings, and we see it routinely on our wards. I think the ability to access mental health resources is also being stretched to a near breaking point here in Cincinnati, and we're incredibly well resourced. So I would suspect that that is similarly being felt in other parts of the country. But I think on the flip side, on a positive side, I would say that the pandemic has, in many respects, forced us toward more collaboration. We could not address all the different phases of COVID-19 without collaboration across sectors of health relevant organizations. And so I think the links between, say, Cincinnati Children's and our health departments and our health information exchange and key community councils is something that I actually hope will outlive this particular pandemic.
Great. We have another question from the audience. You've clearly incorporated anthropology into your work. What are other fields you are using in your health equity efforts? Has design thinking factored in?
Yeah, design thinking has absolutely factored in. Human-centered design is central to a lot of the work that we're doing right now. We're working with a local design firm and actually have peer researchers who are working with us and are in the midst of interviewing their neighbors and community members to think about what possibilities may exist in terms of medical and social care integration. I think the other methods which are central to what we do emerge from quality improvement and learning network and learning health systems. Other methods too, but those are probably the big ones that routinely find their way into our work.
There's a question about Cincinnati Children's and how the institution is approaching interventions that are focused on equality versus those that are pursuing equity.
Yeah, that's a good question too. I think our health equity network and much of our equity oriented work comes at it certainly more from the frame of equity as opposed to equality, or perhaps we try and go a step further into the realm of justice. I think there are other aspects of what is occurring, not just at Cincinnati Children's, but other institutions which take more we're going to provide the same to everyone, even if that is insufficient. I think it's an ongoing debate in different parts of our institution, but I would say in general, we really focus primarily on the pursuit of equity and justice, and that's colored how we've deployed, how we partner, and with whom we are most likely to prioritize intervention.
All right, we have one question left that's sort of a conglomerate of questions focused on sort of how you start to build partnerships with community. I think specifically there's a question about how academics can build those partnerships. And then I'd like to add on, it's been clear that you've really been able to engage the Cincinnati Children's Health system leadership to also partner with communities, and maybe what kind of what those conversations looked like. And then finally, how do you make sure that you're not being extractive to these vulnerable communities?
Yeah, so I think those are all important questions. I'd say first of all, on the institutional side, I think we are an institution like many that value data, and I think being able to present to our leadership, as well as those across the institution with whom we want to partner, with both quantitative and qualitative data, has really helped to advance the case. It says a lot that it's quite meaningful when you're able to show the degree to which inequities are right here in our own backyard. And I think that's been really helpful as we've advanced the conversation with our leadership, with our board, as well as with potential partners all across the hospital who are increasingly interested and engaged as it pertains to equity-oriented work. I think to the second part of the question, that doing so authentically and not to certain communities, but with certain communities, or in many respects guided by certain communities, has been a key way in which we've worked. And so I think, for those who are interested, and I know we're over time, but All Children Thrive, which can be found at actcincy.org, is a great illustration of the ways in which we've tried to bring different individuals and community partners into a singular shared community-wide effort, that it's not the hospital doing this wholly separate from parents, families, community councils, or community agencies, but it's rather a shared effort in pursuit of a shared outcome. And so if you're interested, take a look, and then happy to engage more on that. I couldn't agree more about the avoiding extracted output, but rather being true partners in the work.
Thank you so much, Andy, for presenting today. I think I speak on behalf of all the attendees. It's really been a wonderful talk, and we've all learned a lot. So appreciate you taking the time.
Well, thanks again for having me, and would welcome the opportunity to be in touch.